as we were starting to take a breather following the immense impact of COVID-19 in all of our lives, a new virus started to crawl its way into the public conscience, causing fear amongst those who haven't even started to get back up on their feet after the pandemic. Humans tend to fear those they don't truly understand, and it doesn't help that this virus has such an unsettling name: monkeypox. In this video, we're going to explore the nature of monkeypox, its origins, how it's transmitted, and more, to help us understand how to avoid triggering another epidemic. Before we get started, if you like to stay ahead on knowledge and life tips, be sure to subscribe to the channel and turn on all notifications to stay up to date with our latest videos. Monkeypox is a viral zoonosis, or a virus transmitted from animals to humans with symptoms that are comparable to those seen in smallpox patients in the past. However, it is less severe clinically. Monkeypox has emerged as the most important orthopox virus for public health since the eradication of smallpox in 1980 and the consequent suspension of smallpox vaccination. Monkeypox is largely found in Central and West Africa, particularly near tropical rainforests, and is increasingly being seen in metropolitan areas. Rodents and non-human primates are among the animal hosts. The pathogen. Monkeypox virus is a double-stranded DNA virus that belongs to the Poxviridae family's orthopox virus genus. The monkeypox virus is divided into two genetic clades: the Central African Congo Basin clade and the West African clade. The Congo Basin clade was assumed to be more transmissible and to have caused more severe sickness in the past. The sole country where both viral clades have been detected, Cameroon, has been used to divide the two clades geographically. Monkeypox virus's natural host. The monkeypox virus has been found to be vulnerable in a variety of animal species. Rope squirrels, tree squirrels, Gambian pouch rats, dormice, non-human primates, and other species are among those affected. The natural history of the monkeypox virus is still unknown, and further research is needed to determine the specific reservoirs and how virus circulation is maintained in nature. Outbreaks. Human monkeypox was first discovered in a 9-month-old boy in the Democratic Republic of Congo in 1970, in an area where smallpox has been eradicated in 1968. Since then, the majority of cases have been reported from the Congo Basin's rural rainforest regions, mainly in the Democratic Republic of Congo, and human cases have been reported from all throughout Central and West Africa. Monkeypox has been documented in 11 African nations since 1970: Benin, Cameroon, Central African Republic, Democratic Republic of Congo, Gabon, the Ivory Coast, Liberia, Nigeria, Republic of Congo, Sierra Leone, and South Sudan. The real extent of monkeypox's impact is unknown. In the Democratic Republic of Congo, for example, an outbreak was reported in 1996-97 with a lower case fatality ratio and a greater attack rate than typical. In one example, a concurrent epidemic of chickenpox produced by the varicella virus, which is not an orthopox virus, and monkeypox was discovered, which could explain real or perceived variations in transmission dynamics. Nigeria has been dealing with a major outbreak since 2017, with over 500 suspected cases, over 200 confirmed cases, and a case fatality rate of over 3%. Cases are still being reported today. Monkeypox is a global public health concern since it affects not only countries in West and Central Africa, but also the rest of the world. In the United States of America, the first monkeypox outbreak outside of Africa occurred in 2003, and it was connected to contact with infected pet prairie dogs. Gambian pouch rats and dormice had been smuggled into the nation from Ghana to house these pets. Over 70 cases of monkeypox were reported in the United States as a result of this outbreak. Travelers from Nigeria to Israel in September 2018, the United Kingdom in December 2019, May 2021 and May 2022, Singapore in May 2019, and the United States of America in July and November 2021 have all been reported to have monkeypox. Multiple cases of monkeypox were discovered in many non-endemic countries in May 2022. Studies are now being conducted to learn more about the epidemiology, infection, origins, and transmission patterns. Direct contact with the blood, body fluids, or cutaneous or mucosal lesions of infected animals can result in animal-to-human or zoonotic transmissions. Many animals in Africa have been reported to be infected with the monkeypox virus, including rope squirrels, tree squirrels, Gambian poached rats, dormice, various monkey species, and others. Monkeypox's natural reservoir has yet to be established, while rats are the most likely suspect. A possible risk factor is eating undercooked meat and other animal products from infected animals. People who live or near forested regions may be exposed to infected animals in an indirect or low-level manner. Close contact with respiratory secretions, skin sores of an infected person, or recently contaminated objects can result in human-to-human transmission. Droplet respiratory particle transmission typically necessitates lengthy face-to-face contact, putting health workers, household members, and other close contacts of active cases at danger. However, in recent years, the longest known chain of transmission in a community has climbed from 6 to 9, which has resulted in a loss of immunity in all groups. Transmission can also happen through the placenta, which can cause congenital monkeypox, or through intimate contact during and after birth. While close physical contact is a well-known risk factor for transmission, it is currently unknown if monkeypox may be transferred sexually. To gain a better understanding of this risk, more research is required. Symptoms and signs. Monkeypox can take 6 to 13 days to incubate, from infection to beginning of symptoms, although it can take anywhere from 5 to 21 days. The infection can be broken down into 2 stages. Number 1. Fever, acute headache, swelling of the lymph nodes, back discomfort, muscle aches, and intense asthenia characterize the invasion stage, which lasts between 0 to 5 days. When compared to other diseases that may appear identical at first, monkeypox has a specific feature: lymphadenopathy, or chickenpox, measles, and smallpox. Number 2. The skin eruption usually starts 1 to 3 days after the fever appears. The rash appears to be focused more on the face and extremities than the trunk. The face in 95% of cases, palm of the hands and soles of the feet are all affected in 75% of the cases. Oral mucous membranes in 70% of patients, genitalia in 30%, and conjunctivae in 20%, as well as the cornea, are also affected. The rash progresses from flattened lesions to slightly raised firm lesions, clear fluid-filled lesions, yellowish fluid-filled lesions, and crusts that dry up and flake off. The number of lesions might range from a few to thousands. Lesions can coalesce until substantial chunks of skin slough off in extreme situations. Monkeypox is normally a self-limiting condition, with symptoms lasting between 2 and 4 weeks. Severe instances are more common in youngsters and are linked to the amount of virus exposure, the patient's condition, and the type of problems. Immune inadequacies may play a role in the result. Despite the fact that smallpox vaccination provided protection in the past, persons younger than 40 to 50 years of age, depending on the country, may now be more susceptible to monkeypox as a result of the global halt of smallpox immunization campaigns following the disease's eradication. Secondary infections: bronchopneumonia, sepsis, encephalitis, and infection of the cornea with resulting visual loss are all possible complications of monkeypox. It's unclear how widespread a symptomatic infection can be. Monkeypox has a case fatality rate that has traditionally fluctuated from 0% to 11% in the general population, with a greater rate among small children. The case fatality ratio has been approximately 3 to 6% in recent years. Diagnosis: other rash disorders such as chickenpox, measles, bacterial skin infections, scabies, syphilis, and medication-related allergies must be examined in the clinical differential diagnosis. Lymphadenopathy can be used to identify monkeypox from chickenpox or smallpox during the prodromal stage of sickness. If monkeypox is detected, health professionals should acquire a suitable sample and transport it safely to a laboratory equipped to handle it. The type and quality of the specimen, as well as the type of laboratory test, are all factors in confirming monkeypox. As a result, specimens should be packaged and sent in line with local, state, and federal regulations. Because of its precision and sensitivity, the polymerase chain reaction, or PCR, is the primary laboratory test. Skin lesions, the roof or fluid from vesicles and pustules, as well as dry crusts, provide the best diagnostic samples from monkeypox. Biopsy is a possibility when it is possible. lesion samples must be kept cold and preserved in a dry, sterile tube with no viral transport media. Because of the brief duration of viremia compared to the time of specimen collection after symptoms begin, PCR blood tests are frequently inconclusive and should not be regularly collected from patients. Antigen and antibody detection methods do not offer monkeypox-specific confirmation because orthopox viruses are serologically cross-reactive. When resources are scarce, serology and antigen detection procedures are not suggested for diagnosis or case investigation. Furthermore, recent or distant vaccination with a vaccinia-based vaccine or anyone immunized before to smallpox eradication or more recently vaccinated due to a heightened risk such as orthopox virus laboratory employees could result in false positive results. The following patient information must be included with the specimens in order to interpret data results. A. Date of onset of fever. B. Date of onset of rash. C. Date of specimen collection. D. Current state of the individual or stage of rash. And E. Age. Therapeutics. Monkeypox clinical therapy should be properly adjusted in order to reduce symptoms, manage complications, and minimize long-term consequences. To maintain proper nutritional status, patients should be given fluids and food. Secondary bacterial infections should be treated according to the instructions. The European Medicines Agency or EMA approved tecovirimat, an antiviral drug developed for smallpox for monkeypox in 2022 based on findings from animals and human research. It isn't generally available yet. Tecovirimat should ideally be studied in a clinical research setting with prospective data gathering if used for patient care. Vaccination. Several observational studies have shown that smallpox vaccination is roughly 85% effective in preventing monkeypox. As a result, either vaccination against smallpox may result in a milder sickness. A scar on the upper arm is frequently the only sign of previous smallpox immunization. The original or first-generation smallpox vaccines are not available to the general population at this time. Some laboratory employees and healthcare workers may have gotten a more current smallpox vaccine to protect them from orthopox viruses in the workplace. In 2019, a more recent vaccination based on a modified attenuated vaccinia virus or the Ankara strain was authorized for monkeypox prevention. This is a 2-dose vaccine that is still in short supply. Due to the cross-protection afforded by the immune response to orthopox viruses, smallpox and monkeypox vaccines are created in formulations based on the vaccinia virus. Prevention. The main prevention strategy for monkeypox is to raise public knowledge of risk factors and educate individuals about the steps they may take to decrease their exposure to the virus. Scientific research is currently being conducted to determine the feasibility and suitability of vaccination for the prevention and control of monkeypox. Some countries have laws in place or are considering policies to provide vaccines to people who may be at risk, such as laboratory workers, fast response teams, and health professionals, taking steps to reduce the possibility of human-to-human transfer. For outbreak containment, surveillance and early detection of new cases are crucial. Close contact with sick people is the most major risk factor for monkeypox virus infection during human monkeypox epidemics. Infected health personnel and household members are at a higher risk. Standard infection control procedures should be followed by health personnel caring for patients with suspected or confirmed monkeypox virus infection or handling specimens from them. Persons who have been vaccinated against smallpox should be chosen to care for the patient if at all possible. Samples taken from people and animals suspected of being infected with the monkeypox virus should be handled by competent personnel in well-equipped laboratories. In compliance with WHO guidelines for the transport of infectious substances, patient specimens must be safely prepared for shipment with triple packaging. Clusters of monkeypox cases were discovered in numerous non-endemic nations in May 2022, with no direct travel links to an endemic location. More research is being conducted to discover the likely source of infection and to prevent further spread. While the origins of this outbreak is being explored, it's critical to consider all possible mechanisms of transmission to protect public health. Here's what you can learn more about the epidemic. Taking steps to reduce the risk of zoonotic transmission. The majority of human infections have occurred as a result of an initial animal-to-human transmission over time. Contact with wild animals, especially those that are sick or dead, should be avoided at all costs, including their flesh, blood, and other parts. All items containing animal meat or parts must also be fully prepared before consumption. Animal trade restrictions are being used to prevent monkeypox. Import restrictions on rodents and non-human primates have been enacted in some nations. Animals in captivity who may be infected with monkeypox should be segregated from other animals and placed in quarantine right away. Any animals that may have come into touch with an infected animal should be confined, handled with caution, and monitored for 30 days for monkeypox signs. The relationship between monkeypox and smallpox. Monkeypox has a clinical appearance that is similar to smallpox, a related orthopox virus infection that has been eradicated. Smallpox was more easily spread and more often lethal, with approximately 30% of cases dying. The last instance of spontaneously acquired smallpox was in 1977, and after a global campaign of vaccination and containment, smallpox was proclaimed eradicated worldwide in 1980. All countries have stopped using vaccinia-based vaccines for routine smallpox vaccination for at least 40 years. Unvaccinated communities are now more susceptible to monkeypox virus infection, while vaccination also protects against monkeypox in West and Central Africa. Despite the fact that smallpox no longer exists in nature, the global health sector is on high alert in case it resurfaces due to natural mechanisms, laboratory accidents, or purposeful release. New vaccines, diagnostics, and antiviral medicines are being developed to ensure worldwide preparation in the event of a re-emergence of smallpox. These may now be effective in the prevention and treatment of monkeypox. Thank you so much for watching. If you have learned a lot from this video, be sure to click like and smash the subscribe and notification buttons. Share this video with your friends and family to keep them informed and protected. See you guys in the next one.